We want to make sure our diagnosis is right. So looking at some tests that will prove us right. So there isn't one specific test.
There never is there?
No, there's no one specific test. So it's using a cluster of tests, which will give us that sort of green light to think, yeah, I think we're on the right lines here. So you're putting a subjective together. You're looking at objective posture, how you're standing. You're looking at strength as well, which we'll come on to. But specifically trying to get that diagnosis right, there's a few tests that we use that are kind of proven within the research to be the best, if you like. So while we're standing, we'll use Stephen as a wall, if that's okay. So standing on one leg. So if you put your fingertip on Stephen's back, and then we're going to lift this leg. So you're standing on one leg, you're lifting this leg off the floor. So this is the test, this is the hip that we're testing. It's the sustained stance test. So quite often in a hip that's painful, this will bring the symptoms on straight away. And you'll say, where are you feeling it? And it's usually here. If you're not getting anything straight away, then you can wait 30 seconds and see if that reproduces the person's pain. And what you'll often see is that lateral shift. So if you go into, you'll often see this. So we've got that compression through here. And often dropping down into adduction as well. So this is a test so you can pop that leg back down again. So it's ruling the condition in. Okay. So if it's positive, it's likely that it could be likely they've got gluteal tendinopathy.
Positive being it's reproducing the more or less the exact pain that they complain of.
Absolutely, yes, that's my pain. So if it's reproducing pain in their back, but their concern is here, then it's negative. It's got to be reproduction of their exact pain. So this is a test that we would use within our battery of tests to try and hone in on that diagnosis. It's quite easy to do, and it's functional. So it's a nice test to look at, but on its own, it's not going to give you that definitive diagnosis. So the other tests that we tend to use within this battery are lying down. Okay. So if we get you lying down, so if you're lying aside first of all, so on this side. So for us to have a
this is the side we suspect, isn't it?
This is the side we suspect, yes. So one of the cardinal signs of gluteal tendinopathy is pain over the greater trochanter. Okay, so to find the greater trochanter, it's obviously it's that sort of knobbly part of the femur. But if you start in the iliac crest and just run your hand over and down the mid thigh, you'll come across that sort of area that sticks out. So that's that's where the greater trochanter is. So palpation and tenderness of that has to be positive for us to have a positive diagnosis of gluteal tendinopathy. So this has to be positive along with one or two of the other tests that we're doing.
And at the moment, hips are more or less in neutral, aren't they?
Yeah, it doesn't really matter so much how they're lying. I mean, you'd probably, if we're being picky, we'd pull the hips back a little bit, but it's more about palpation and making sure that spot is tender. If it's not going to be gluteal tendinopathy. Okay. So that's when you maybe think, okay, maybe it's coming from the spine, or is it the hip joint that's involved more? But that's got to be positive.
So why might it be tender there and not be gluteal tendinopathy? What could it be?
So it could be the spine. So you could have a referral pattern coming down from the spine. It could be the hip joint. So we just need to explore those in more detail. But if you're getting all the other tests, but that's not positive, then it's not likely to be gluteal tendinopathy. So this will rule it out. So if it's not tender, it's not gluteal tendinopathy. So if we get you on your back now. So the literature shows that tests that have a compressive force and also a tensile, increased tensile load, so where the muscle's active, they are the most likely to reproduce a positive, because they're doing the increased tensile load and the compression together. So one test that we use, I'm going to use this leg, is the fader. So you can do fader and fader plus R, so that's with resistance, okay? So we're going to take the hip into flexion, into adduction, and then external rotation, okay? So we're really compressing the gluteal tendon here against the greater trochanter, and we've got that adduction and flexion. So we've got the ITB in that lengthened position, so we've got passive tension going through it. Okay, so this is the fader test.
Just out of curiosity, how much force are you going to put into that? Are you just taking it into a...
So I'm just taking it into that position. So I've not got any force going through there at the moment. The next step is to add some force in. Yeah. So what I'm going to say is I want you to bring your foot back to neutral. So I want you to bring your foot back this way, okay? And I want you to try to resist me. So I'm going to just put you back into that position. That's it. And now I want you to resist. That's it. So by adding that tensile load with compression, they often go, yep, that's exactly the pain. And again, we're looking for reproduction of their symptoms. Yep. So that's a nice test to do. And then if we get you on your side again, so we've got adduction. So inside lying, we're going to go down into passive adduction. So we want the hip to be in relative neutral, so it's not flexed, not extended. And often that, again, we've got that passive tension through ITB, that will reproduce symptoms, but we can also add that tensile load. So if you try to, I'm going to try and resist you, push you down, you try and take your leg back up to the ceiling, okay? So just adding that resistance in while the hip is in adduction will often reproduce pain here.